remote thing. So we are starting our clinic. A very good afternoon and a very warm welcome to NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG ma'am, Professor Urvashi Singh. I welcome directors and team from NIRT and NTI, state TB officers, directors of STDCs, faculty of medical college, district TB officers and all others. A very warm welcome. Introducing the faculty from NITRD, I am Dr. Neeta Singla. I am Nodal Officer, DRTB Center. On my right is Dr. Rupak Singla. He is consultant in Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is a senior pulmonologist at NITRD. We are joined by our director, Dr. Manpreet Bhalla ma'am. I would request her to give her introductory remarks. Over to Dr. Manpreet.
Good afternoon, everyone, and welcome for this NITRD clinic, which is being held in collaboration with Central TB Division and the National Task Force. And as told by Dr. Neeta, we are joined by Dr. Urvashi, who is the DDG TB, Professor Bhardwaj, the chair of NTF, and also we have the experts today, Dr. Rajendra Prasad, who is the vice chair of NTF, and Dr. Rupak Singla from our institute. Also, the case presentation today is by Dr. Rishi Saxena, who is the STO UP Joint Director TB. So I welcome you all. And so today's topic is drug-sensitive TB, not responding to treatment. So I think many of us many patients are facing these problems these days. And so we need to do something. And even in our institute, we took up this initiative of doing the therapeutic drug monitoring. So we started this and we are already doing it for the first line drugs. And I think Dr. Singla will be able to share his experiences, like what are the benefits of doing this therapeutic drug monitoring, how it's going to help the patients. And all the doctors who have joined today, I think it will be, they can discuss here, and they can also, from the experts, they can take their opinion, like when we should do this, it should be done, and how it's going to help the patients. So thank you, and I look forward to good deliberations and wish all the best for this clinic. Thank you.
Thank you so much, ma'am. Now I request our DDG ma'am, who's always there to encourage us, and she makes sure that she's there for every clinic of ours. So I would request her to give her address.
Good afternoon, everyone. And I must start by thanking Dr. Manpreet, the director at NITRD, the esteemed team at NITRD, who have so painstakingly continued to do the difficult to treat clinic. And this provides guidance to all the, throughout the country, all our DTOs, all our MOs, and it is something that we also always look forward to. So the clinic today is honored by the presence of esteemed seniors like Dr. Bhatnagar, Dr. Rajendra Prasad, Dr. Singla sir, who will be actually enlightening everybody with their experiences. The topic for today is very relevant in today's times, because as we grow wiser, earlier patients who would not be responding to DSTB treatment would clinically be called as MDR-TB and possibly, move to MDR-TB treatment regimen, which had its own issues. They were longer, there were side effects, and so on and so forth. Now, with the knowledge of therapeutic drug monitoring, that is the pharmacokinetics of drug absorption, we now know that the drug levels may not be adequate, which could be due to the individual factors of the patient, like drug absorption may not happen, or drug metabolism may be faster. Again, we traditionally are not really looking for patients who can metabolize drugs faster. We are not routinely looking for drug levels, but the experience is suggestive that we may start looking for drug levels, especially in patients who don't start responding by the time we expect response to come in. There have been several publications from India, some from NITRD, some from our group at AIMS, where we have highlighted patients who have not been responding, are possibly not responding because the drug levels are not reaching. NITRD, Dr. Singla sir, even the pediatric group under Dr. Sangeeta has published in pulmonary TB, while we at AIMS have published one in category 2 pulmonary TB, erstwhile category 2. And we've also published in the area of abdominal TB when the drug absorption was found to be poor. There is a publication under communication in TB meningitis, where we still continue to use the drugs used for treatment of pulmonary TB, and which is not ideal, but the recommendations are those. So currently, the TDM data has guided us to look for possible different regimen, which may prove to be better in extrapulmonary TB. So, with this brief, I would request and thank Dr. Neeta Singla profusely for leading this effort for several years now. So, thank you, Dr. Neeta, and I'd request Dr. Rishi Saxena, who himself is a very committed program officer, and we really marvel at his persistence and his hard work with the patients in UP. So thank you all for patient listening.
Thank you so much, ma'am. Thanks a lot. And now we start our clinic. So today's case is from the state of Uttar Pradesh, and the case presentation will be done by Dr. Rishi Saxena, who's the Deputy STO UP. He's also the Joint Director TB at the Directorate at Swasthya Bhavan, Lucknow. Sir, a very warm welcome, and I think DDG ma'am has already said such nice words for you, so I really don't need to say anything. And the national expert for the day is Dr. Rajendra Prasad sir. Sir is at he is the Vice Chair NTF, and he is Director Medical Education at ERA's Lucknow Medical College. Sir, a very warm welcome. And now I would request Dr. Rishi to start his case presentation.
Okay. Good afternoon, ma'am. Respected DDG ma'am, respected Director NITRD, respected NTF Chair, respected Vice NTF Chair, NITRD Consultant, Dr. Singla sir. It's my privilege as Dr. Saxena, I am Deputy State TB Officer, Joint Director, being presenting the case of this today's case presentation. Now the case history says that it is a 19-year-old male patient.
So before you start, can you put it on the PPT mode? We can see the presentation mode.
Madam, it is in the presentation mode, ma'am.
So here we can see all the slides. Maybe you need to screen share again.
And slides are not moving also, sir. You can just check.
Pardon, madam. Just madam. Yes, madam. This one is this one. I'm closing it, madam.
Sir, कोई बात नहीं, आप आराम से कर लीजिए, हो जाएगा.
मैडम आ गया?
नहीं, अभी नहीं आया सर, दोबारा करिए. अगर आपको प्रॉब्लम होगी तो we can always do it from here, but अभी आप ट्राई कर लीजिए.
Okay.
ठीक है सर, we can see it now.
आ गया. Okay, sir. Okay, sir. Okay. So this is a case of a 19-year-old male patient who is a resident of Kanpur. He had a history of cough with expectoration and high-grade fever in February 2023. He was then treated by a local practitioner, and he also took injection amikacin for 7 days from another practitioner, but he was not cured. So patient was admitted in Moraila Chest Hospital Department of Medical College, Kanpur, and his sputum report on NAT was positive with rift sensitive on 17th of April 2023. A follow-up culture and microscopy was done. It was negative. Full adherence patient took from 18th of April 2023 when the treatment was started till 2nd October 2023. The outcome of this patient was reported late on 10th February, but clinical improvement was seen. This was the first time patient had taken treatment. Just a minute. This is the X-ray at the time when the treatment was started. Here we are seeing there is a opacity, heterogeneous opacities on the left upper and more on the middle zone of left lung. Apart from a slight parastello OPD on the right side. Now this is the details of the test done. It has been taken on the Nixia ID. The first Nixia ID was this one, and the NAT testing was done on 17th of April, where MTB was detected, rift sensitive. Patient treatment DSTB was started, completed all 6 months. Then follow-up of the microscopy as per the two, it was negative. Then culture was also done. In the meantime, it was also negative. Then follow-up microscopy at the end of treatment was also negative. So both of the samples, then after 3 months back, also the samples were taken on the same Nixia ID. They were also found negative. So on 2nd of on 10th February 2024, the treatment was declared as treatment cured. But after a gap of 3 months again, patient developed fever and cough, which restarted in January. The treatment outcome was completed in, it was declared as cured. Then patient again went to a local practitioner, took treatment for 6 days, but no relief. Then again, patient came on 20th February. The NAT was done, The NAT was done, and it was again MTB detected with rift sensitive. It was done from a government hospital. Patient also the DST was done from a private lab on 5th of June 2024. Patient continuously took this DSTB treatment from 23rd of March to 6th of September. 6 months continuously. I have seen his ID also. The adherence part in the Nixia also showed all green. The outcome was declared as failure on 5th of September. This was the second time when the patient has taken treatment. This was the phenotypic DST which was done from a private lab. Here it showed a moxiflox resistant, which we were not giving at that time. Now this is the second time all the reports which were done for that patient, follow reports are there. Here you are seeing the NAT testing was done on 20th March. Same MTB detected, rift sensitive. Then FLLP was done, MTB detected, rift resistance not detected. Even H high level or low level was also not detected. DST smear and culture was done, where it was found Z and lineage susceptible. Then follow-up microscopy was done on 13th of 2 months, again negative. Then SLLPA was done again in the month of May. It's the same. MTB detected, resistance to levoflox and MOX was not detected, and even SLI resistance was also not seen. Then culture was done again from the private, which I have shown. It was done on the 5th of June. Here it showed a moxiflox resistance, which in the previous slide I have shown. Then follow-ups, the end of the treatment, the follow-up microscopy was done, which was found positive. So the outcome was declared as failure. In the same ID, then again, on the same ID, the follow-up was done. Like NAT was again done, MTB detected, rift sensitive. Microscopy was done on 26 September. It was negative. Culture was done on 30th October. It was positive. Then FLLP was done on 21st of November. Same. MTB detected, rift resistance not detected. The treatment was completed in September, but the follow-up and all that was still showing MTB detected, and other resistance were not detected. Again, the symptoms occurred. So patient went, then contacted private practice. Patient went to a private practitioner on 21st August, and ultimately he was referred to a private medical college, Rama, on 2nd September. Before that, patient took some treatment from local practitioner for 6 days, but no relief. There, sputum samples were sent for smear, culture, TrueNet. Same TrueNet report MTB detected, references not detected on 11 September. Culture was positive on KGMC report, as I have shown in the previous slide, 30 October. Then the consultant at Rama Medical College, Dr. Sudhir Chaudhary, then sent this case in consultation with the team of NIT-RD that the blood sampling should be done, therapeutic monitoring of this sample should be done. Now here you are seeing the X-ray. The X-ray shows the opacities on the left upper and middle zone has now increased. On the both the upper zone is also there, and the middle is also increasing, and also the cavitations is also seen here on this side. The two cavitations are seen, this one and this one, in September X-ray report. This is the, again, patient the DST was done from private lab in the month of October, the report of which came in 1st of November. Here you are saying the same thing, moxiflox low dose resistant. This is the third time. The patient's treatment was started on 10th of September. Again, the treatment was started, and still patient is continuing this treatment. The same treatment patient is continuing. As you are seeing the report, there is no change in the report. On 6th September also MTB detected, RIP sensitive. Then 11 September also MTB detected, RIP sensitive. Microscopy again negative. Follow-up also again negative. FLLPH 16th of October. Again, same thing. MTB detected, RIF resistance not detected. INH high level, low level not detected. Culture again was done on 30 October. It came positive. Then DST was done on this. I have told that from private lab, here it showed moxiflox resistance, which we had not given at yet till date. And on 18th of December also, microscopy was negative. These were then when during the conversion, this patient was sent to NIT-RD, where the drug therapeutic level monitoring was done. And here we see some results which are very which we have to consider, as DDG madam has highlighted the therapeutic range also, that why the concentration of INH and rifampicin here you are seeing is not at par, it is below the therapeutic range. This may be the reason that the patient is still showing the positive results, except parazenamide, whose therapeutic range is within the normal range. So based on all this, the patient's treatment was third time started from 10th of September till 19th of January. I've seen his treatment got also. Then this also it was done, but at the same time, the weight of the patient has started reducing from 40 kg to 38 kg during the third time treatment. These are the cards. Now here you are seeing the haziness is somewhat diffused. 19-20 hai from September to October. But here you are seeing on 10th of October, the haziness is there, cavity is also there. These are all the reports here. If you see from 2023, the haziness is continuously there, somewhat decreasing and increasing. And this is the latest X-ray on 14th of 1 week back, on 14th of January. Here you are seeing dense opacities. Two clusters are there on the upper and middle zone on the left side, and also there is a new opacities present on the right upper and middle zone border. Here. So the patient went to the cardiology on 20th January. His BP was normal, but QTC interval also had a sinus rhythm with right ventricular hypertrophy and RAD, and there were normal serum levels of sodium, calcium, and potassium in cardiology. This is a summary of all the three types of follow-ups were done. Here you are seeing the same reports. The first microscopy was same. The second microscopy only last follow-up came positive in the second time after treatment. The culture was positive at the second time, so it was declared failure. And third time, it is continuing. Now, concern is that since 3 times JC treatment and his NAT report shows MTB detected, RIF sensitive, with no low dose or high dose H resistance detected. No history of interrupted course on all the three DSTB regimens with timely follow-up as per the diagnostic reports. As talked with patient myself, patient is clinically fit, but X-ray shows increased heterogeneous opacities in the left upper and middle zone with cavitations. Therapeutic drug levels in serum were low despite adequate doses of R and H and Z, except the plasmid level was quite low, was adequate, sorry. So our concern is that patient, what type of regimen can be given this regimen, or based on the reports, can we start our oral long regimen? Thank you to all.
Thank you, sir. Thank you. So you can stop the screen share.
Sir, madam.
So, yeah, so before we take questions on the history of this patient, for the people who have joined us little later, I'll just give it in very brief. This patient has received ATT thrice. First time he got cured, and then again after 2 to 3 months he became symptomatic. And on CBNAT he was diagnosed as TB, but RIFA was coming as sensitive. So a patient was continued on treatment in 2024 from March till September. During the treatment, he had converted to negative, but at the end of the treatment, he became failure in the September. And that is the time where his therapeutic drug monitoring was also done. And in the therapeutic drug monitoring, the levels for RIFA and INH has come as low, but for parazenamide, they have come, they are in normal range. And his of September, October, and all the follow-up cultures are coming positive, but he's sensitive to rifampicin, INH, both the drugs. And his X-ray has been deteriorating. He has lost 2 kg of weight, though he's clinically okay. Patient is currently on EHRZ with effect from September 24. And now Dr. Rishi wants to discuss that what should be the treatment be given to him as he's coming as RIFA and INH sensitive consistently. So we'll open it for discussion. We'll open the forum for discussion. You can ask any question on the history before we go on to the treatment.
I would just like to ask Dr. Rishi whether the type of medication the patient was given, whether it was a FDC preparation or individual drugs were prescribed, whether it was from government store or it was a private initiative.
Sir, it was the whole the fixed dose combination. It was given from the government. Patient had taken all the medicine 3 times from the government only, sir.
So, Dr. Rishi, any reasons to suspect that the quality of the drugs might have been compromised?
No, sir, no, not at all. Because the same drugs are given to the other patients also, and they are being cured. We have the treatment success rate is around over 90% in our state, sir, of DSTB. Because I'm looking at that also. So there's no question about the quality of the drugs, because these are all active drugs.
So would it be appropriate to analyze the cohort of patient who was prescribed the same batch of medication?
Sir, it can be done, but it will be quite difficult to know, because the treatment has started way back in 2023. It was completed. Now the next batch has been come. For that, sir, we have to do intensive investigations.
Yes.
Because if in that case, if the patient had taken the same batch, if one patient has taken and the rest are cured, then this might not be a case that the drugs or say of that batch, particular batch, might have been damaged or something different. Because if this case might be there, then all the patients of that time when these drugs were given, then all those patients might be having the same result also, sir.
Not all, but this remains an area of suspicion. Needs investigation from your side.
Sir.
ऋषि जो प्राइवेट लैब था वो एक्रेडिटेड है, वो क्या नहीं है?
नहीं सर,
जहाँ टेस्ट लैब है सर, लैब में वो एक्रेडिटेड है कि नहीं है?
नहीं सर, वो पेशेंट करवाया है, और एक नेक्स्ट टाइम मैं प्राइवेट मेडिकल कॉलेज में गया था तो वहां पे डॉक्टर चौधरी सर ने नाम लिखा, और मे भी उन्होंने
That I know. रामा में तो डॉक्टर चौधरी हैं, तो वहाँ
सर
Dr.
सर उसमें मॉक्सी
Rishi,
सर उसमें मॉक्सी रेजिस्टेंट
KGMU,
आया है।
Hello.
भारत जी मैम,
KGMU confirmed it to be M tuberculosis.
जी मैम, उसमें मैम because the culture
Culture.
report, madam, the culture report of 2 times of culture report has been done. The first time
Third
culture
time?
report,
Third time?
madam, third time it is not done. Madam. The last culture was on 30th October 2024, madam. Here it was showing positive, ma'am.
When
From
was the
KGMU.
last treatment regimen started?
Madam, the last treatment was started on 10th of September 2024, the third time. Patient is still continuing the treatment, madam. I have
And
seen
when did the last regimen, the follow-up smear was positive last?
Madam, the last smear was positive on 6th on September, September 6 September, and the outcome, sorry, on 4 September, and the outcome was declared as failure because the last follow by the macroscopy was done in DSTB case. So it was positive because I have seen the treatment card also. It was showing +1 in the treatment card in the follow column. So
What is the status now? Is he smear positive, culture positive, or no? Now.
Madam, at present, madam, the last sample on 18th of December was done. The microscopy was done. It was found as negative, and the X-ray only shows, madam. After that, no any other test has been done, madam.
And any comorbidities or what is the BMI?
No, ma'am.
What
Madam,
is the BMI?
Madam, BMI, he's 40 kg here, madam. When I personally talked to him and I seen his photograph also, he's at that time in starting he was not able to go to hospital also. He himself said, but now he went to hospital on even 20th also, and he came back and he stayed for 3 or 4 days during with the ECG was done, and his all the investigations like serum, sodium, potassium, and calcium were done, and he stayed back.
So
and
he's
came
low
back
BMI.
home.
You're saying he's low BMI. Such
Yeah.
patients, drug absorption is known to be affected. I remember a case that was discussed in the same difficult to treat TB clinic, where we brought this up earlier on also, that for good drug absorption, the patient's intake of good food and protein-rich diet has to be there. So possibly you could have supplemented him with, supplemented him with nutrition. Good diet could have been suggested. The drug absorption does get affected. So changing the regimen is not the answer. Enhancing the drugs, dosage could be one. Sir, I'll just finish in a minute, please. Dosage enhancement could help. And of course, the nutrition support could help.
Problem
Okay, ma'am.
Yeah.
Yes, sir. Dr. Rajendra Prasad, sir,
I believe. Yes, still you can.
Sir, we can hear you, Dr. Rajendra Prasad, sir. Sir, you are audible.
Thank you. I think the case has been very well presented. I am audible?
Yes, sir.
Yes, sir, you are audible.
I think the case, I must compliment Rishi that the case has been presented very well and has been worked also thoroughly well, I must say. One or two points I would like to ask that first thing, that what was the HIV status of this individual, because I could not find in the case presentation anywhere.
Sir, HIV was negative, sir. Sir,
HIV was negative.
Negative, sir.
What? Has anybody in the family had diabetes, or what is the status of diabetes of this young? Although he's very young, he's a 24-year person. But what is the status of diabetes?
Sir, he is non-diabetic, sir.
He is non-diabetic. Very well. And the third point I would like to ask, that since he has been, this is the third time he is getting treatment, and so what has been the adherence? Has somebody really judged that has he been adherent to these all treatment what he has been prescribed? And because I could not see any adverse drug reaction problem
Sir.
with this child. So that sometimes raises a question. Adherence was really was there.
Sir, I had
Because we
seen
have
his
to search
treatment.
why he has failed. One of the
Exactly,
reason
sir,
is
exactly.
visible. Uh, One of the reason is very obvious that in the therapeutic intidium, the level of rifampicin and isoniazid is very poor. That could be one of the reason why he has failed. And the last point I would like to raise that currently, as I have heard, because there was some internet issue in between, as I've heard that patient is only that we are worried with the radiology, though his lesion was too big to me. When I saw the first X-ray, there was a little lesion on right side also. Of course, the main lesion was the left side, but then now those lesions have progressed. There's no doubt about it.
Yes, sir.
And in last 3-4 months, I believe the lesions were stable. And what I have heard because of some internet issues that his sputum is negative. His sputum for AFB is negative currently, and patient is clinically also looks like stable. Rishi, I'm right?
Stable,
Yeah,
sir.
something
Yes,
you have
sir.
to
So
say.
you're absolutely right, sir.
Clinical.
Absolutely right. Sir, I asked, yes, sir. I asked the patient that previously when you were 100, so how much you have improved? He said 70% I have improved.
Okay,
I
because
started
is the patient is a low weight, 24-year man, 40 kg, 38 kg. So her BMI is definitely, I believe it will be less. So
sir.
nutritional issues has also to be addressed in this patient. How much is nutritional assessment and what else does he require? And that is another issue where I'm seeing because the drug sensitive TB, this is not a very common phenomenon. As a clinician, I may say that when we treat hundreds of drug sensitive TB patients, this is not a very common problem. This is one can say not a very common problem. But then one has to address why he is not responding. And one of the factors which was clearly visible was the drug levels were not achieved. Now then question arises, why drugs level were not achieved? Is there some malabsorption syndrome? As you said, HIV is negative.
Yes.
Is there some chronic abdominal problem patient might be suffering? So those also thing has to be addressed very clearly.
Sir, regarding the adherence part, I
And
was also
I do not
in a
think
dilemma.
that is my thinking.
Sir,
And
sir.
clinically is also stable. So you may continue. Only thing, can we think of increasing the dose of rifampicin? That is another question will arise here. I am putting this question to Singla also.
Sir, regarding the drug adherence part, I was also in a dilemma. I think patient had not taken, but I saw all the treatment cards all of the 3 times, and also in the Niksha also they were all green. In the first part also the address column, when I put the ID in the Niksha and it was in the address part, it was showing green part. And second time also I saw his treatment card also, it was marked or ticks. And third time also from till the 19th of January, it was all red. The patient is regularly taking the drugs, sir. This was my concern also, that patient might have not taken the drugs. He might taken in between off and on interrupted reason might be there, but there was no such issue or being found, sir.
All right, sir. Thank you so much. We are joined by Dr. Shakil from Bangladesh. Sir, you have a question. You've raised your hand.
Yeah. Thank you very much. It was really a nice presentation, and
Thanks,
I
sir.
really enjoyed this thing. And the data that has been kept so thoroughly, I must praise the people who have been behind the case. But such a case, you see, the one thing is there, is that have you done the gamma interferon level for this child, for this person? Because the gamma interferon is something, if it is deficient, it can get severe. Even with drug sensitive TB, you can't keep.
I think we have lost the connection.
Some internet problems.
Yeah, so we'll resume once he joins back. Meanwhile, Dr. Puri wanted to ask a question. Over to Dr. Puri.
My question to Dr. Rishi is that since you have given 3 courses of anti-TB drug,
Sir.
and whenever you have done the CBNAT, it is positive,
Sir.
and you have detected the MTB. But when you have done the microscopy, it is usually 80% time it is negative.
Sir.
And patient is improved clinically every time with your treatment. And the one culture is negative and otherwise culture is also positive.
Sir.
So since the sensitivity of microscopy is very variable, so I have to ignore these results and I can say that the patient was not fully cured with any course. He may require a longer duration of treatment. Second point, I want to know that the parazinamide drug resistance, you have said that it is sensitive from where it has been done. Because the patient's drug pattern has been sensitive for H and R by the CBNAT and the LPA, you have said it has been done, it was sensitive. From where the parazinamide sensitivity is done, and I don't believe on these 100% on the sensitivity of parazinamide and ethambutol, whether it is sensitive or not. If these drugs are not sensitive, then 6 months of treatment will not help this patient. The patient will show the clinical improvement, and as you will stop the treatment, he will come again with the sputum positive report. So that is there. Second question is your drug levels. In the drug levels, you have said the drug levels are less. But my question is that if the drug levels are low, then why the patient has not developed the resistance to H and R? And you are saying that the H and R are still sensitive. That is the question we have to answer. That in spite of the low drug levels, the sensitivity is still maintained. So that indicates that the patient is taking drugs regularly. The drugs are okay. No resistance is developing to the rifampicin. Probably if the patient has resistance to parazinamide, most probably that's why the 6-month treatment is not good enough to cure the patient. At least 9 to 12-month treatment should be given in that case.
Sir.
Thank you.
Sir, regarding the status of the parazinamide, it was done. The DST was done in KGMC on the first time, and it showed the linezolid and parazinamide was susceptible to this one, sir. It was done in 2024, I think, 2023 report measure, and since now all the 3 times the NAT report is showing the same thing: sensitive, no INH, low or high level detected, MTB detected. So previously, I was thinking that it might be a dead bacteria, the DNA of which is showing every
But
time.
It may be resistant to ethambutol. It may be resistant to ethambutol.
Sir. So this was my concern, sir. It may be because
we don't have DST. Check the parazinamide and ethambutol resistance also at this time, and accordingly we have to treat the patient, and we may require a longer duration of treatment in such cases. Yes, in the patients where the LPA is not done in the drug sensitive cases, and I find that the LP report is not available, then we should increase the duration of the treatment, because we do not know the INH sensitivity or resistance pattern in that case, though the patient is showing clinical improvement.
Sir, regarding,
because these are must. If the INH and rifampicin are must, universal DST is there. If it is not there, then what you will do at the end of the 6 months? That is another question to the audience that we should.
Second point, Rishi, I would like to raise.
Sir.
I think we've lost the connection again. So I would request Dr. Shakil to complete. He had got disconnected. Dr. Shakil, are you there?
Yes, sir. Am I audible?
Yeah, you're audible, sir.
Yeah.
So thing is that that's another area which these types of case, because these are not common, this is a rare case, because every time you are giving, there is some response for particular period of time, and there is no response. So in that case, you can go for two things there. One is that gamma interferon level and gamma interferon receptor. So these two things, if you do it, probably this patient might get a help, though gamma interferon is one of the costliest drug in the world currently. It's very, but probably we can at least read the diagnosis for the patient. That's from my point. Thank you very much for allowing me to participate in the session. Thanks a lot.
Thank you, sir.
Okay. Thank you.
Recently, we counted one such cases with low gamma interferon level, and it was really costly. About in Indian rupees, it was 25 lakhs rupees to purchase. So for that patient, we could not purchase that. But as Professor Rajendra Prasad has said, we had supplemented the patient with sufficient nutrition and other things, and continued the treatment with that, with the two-drug therapy for about 12 months. And with that two-drug therapy, our situation has been lessened much. So that's an anecdotal one. We are going to publish the report soon. But just to add to what I have said with our experience. Thank you very much once again.
Thank you, sir. Rishi sir, I have a small observation that for the first time when the patient took the treatment, he completed the treatment and he was declared cured, and the sputum smears were also negative. And he developed the symptoms after 3 months while college relapsed. So that means he responded well to these ATTs in the first time when he took the treatment, and second time they are not being absorbed. Another thing which I would like to say is like the patient when he was taking first time ATT, he was a child, 16, 17-year-old. Now he's 19-year-old.
Yeah, ma'am.
So in rural setup, these I'm sure you must have looked for any parasitic infestation in these patients, which is quite common, which can lead to malabsorption of drugs also, ATT. So have you looked into that, sir?
Madam, regarding because in this case, madam, now we have to see because the patient is going on treatment. These things now we have to see the detail at what is the reason. It may be the parasitic infection, because till now, madam, we have not thought on that lines yet. Also, the malabsorption may be the reason. On that lines, I will ask the patient, and I'll be also tell the team to investigate it. But on that line, we have not investigated it. Regarding madam age, at present he's 20 years.
Okay.
So that his 20 years, the problem started when he was at the age of 18 years.
Yes, sir. So there's another comment in the chat box. She's Dr. Gunjan, who is asking whether the ATT, because this is also common practice in the community, which we see the patient divides the ATT into multiple doses, like they may take in 3 times in a day. So was he taking the drugs at the same time, all the FDCs at the same time, or was he taking into divided doses?
Madam, I had asked treatment supporter, because I had to the number of the from the patient who was a treatment supporter. I took the number. I personally asked him how you give the treatment. The patient, so the treatment supporter said, I used to give, or I'm giving that patient that same drug, and he's taking on a regular interval. Sure. There is no morning evening, because it's quite. And this patient resides 5 to 6 kilometers away from my house, actually, in Kanpur.
Thank you, sir. Dr. Lukendra has raised his
Dr.
hand.
Rishi,
Ji, ma'am.
Sorry, ma'am. Sorry to interrupt you, ma'am. Please carry on.
no, I can come after. That's fine.
It was very well presented, Dr. Rishi. I did not heard whether patient had history of alcohol or tobacco smoking.
Sir, patient father also there, so I don't think, and he's a now 18 to 20-year-old, I would say, on a youth age. So I
It's
don't,
okay.
at present, there is no history. Yeah, there is no history suggestive of alcohol or something like that, sir.
Okay. In continuation of my question is, whenever you did the sputum examination, that was done net only. Whatever I know, I may be wrong. If any microbiologist can correct me, the CB net is to not to be done when history within 5 years of ETT is there. Every time you did the CB net to diagnose. So this message has to be clear whether we have to re-test by CB net or some other test also. Although the patient seems to be a case of tuberculosis, lesion was increasing, patient is symptomatic, it could be a case of tuberculosis, but your first diagnosis in all the 3 times you did CB net. When I read the WHO guideline, whether they said if you have a history of pulmonary history of ATT within 5 years, the CB net could be positive.
So you're absolutely right. But they did culture. That is what I asked him earlier. The
That is another thing.
last culture
I
was
understand.
in October
May,
2024.
may I come in, madam? I am agree with you, but thing is, ki message should not go like that, na? If they have done CP net only.
Absolutely, I agree with you. This is what Dr. Rishi,
Yeah, ma'am.
the diagnosis has to be based on culture if there has been
Yeah.
recent treatment. So this message has to get through. Your case, you're right that culture grew. But what Dr. Sab is trying to say is correct, that we should not be using NAT as a diagnostic modality if the patient has been treated in the past few years. And that cutoff is very tricky. Some people say past 2 years, some people say 5 years. So,
And the
yes,
receipt,
sir. Yes, sir. But there is no definite this thing. But there is a gray line between gray zone between 2 and 5 years.
Okay.
but since
Dr.
I
Neeta,
agree
can
with
I?
Loken that I agree with Lokendra and Madam that ideally the follow-up gene expert, a CVNAT should not have been done because follow-up these tests are not for follow-up. Follow-up is only sputum AB or culture, and that has been done. My one
Yes, sir.
question,
Exactly.
I think. My one question: the culture which was done from the private lab, is that private lab is under quality control or not? This is my ignorance. I'm just asking.
Sir,
That
at
particular.
present, sir, at that present, this Aligas lab is a overall lab, is present everywhere. Like we have Lal Path lab.
No, I know.
But we don't
I
know
know
the whether it is RHC accredited or not, sir. Yes, sir. But we don't know the status of whether it is accredited or not, sir. So I cannot comment on that, sir.
I think KGME also gave a culture positive. When was that?
Yes, sir. Yes, sir.
KGME was
30th
culture
October
positive and has shown that the bacteria was sensitive except the moxifloxacin.
No, sir.
I can gather from you.
So no, sir. Some moxiflox report was from the Aligas private DST lab.
Yeah,
report,
from the Aligas.
Yeah, yes,
otherwise, the KG culture says that it was all sensitive.
Sir, the first culture was negative, but the second culture came positive, sir, on 30th October 2024.
Okay.
I would like to bring in another angle altogether. Have we thought of non-tubercular mycobacteria? The DNA that is getting picked up could be TB, but have we ruled out non-tubercular mycobacteria? Just for the sake of completion, there is no debate about the MTB because the October, we just 3 months from October, November, December, and January. So my initial comment that we could increase the dosage of the essential, of the drugs, supplement him with diet, ensure that he's taking the diet and the treatment. His absorption of drugs would improve, enhancing the dose. in the initial few days could overcome the low levels, and of course, later one can decide whether to bring down the dose. Once his levels have been achieved and are maintained. But if like you said, the patient is healthy and there are shadows, one could look for NTM as well, along with the TB if there's a co-infection. If that is leading to more zones of the lung getting involved. So just for the sake of completion,
We should do
Thank
the
you.
sensitivity.
I
Ma'am,
totally agree with Urvashi that the patient, probably
Manjeet,
the
yeah.
drug has to be continued. Probably one has to increase the dose of rifampicin if it is possible, because rifampicin studies all has been done to the dose up to 30 to 35 milligram per kg body weight, and it is well tolerated. And the third thing, as Urvashi said very rightly, the NTM part also. Sometimes both the bacteria, MTB and NTM, they coexist together. So that also has to be taken care of. And another point is his nutrition, because to me his BMI must be very low, so his nutrition has to be sufficiently tackled. And another issue, probably talking to the patient personally and to the family personally, if you can brought about any other factor which might be responsible for the malabsorption, for the uh, therapeutic drug levels are so low as far as INH and rifampicin is concerned. Those things has to be tackled before we could think that one has to shift him onto the further line of treatment. As Rishi has asked a question that whether we can go to all or a longer regimen. So, and especially what I'm seeing last 3 months, he is quite stable. His lesions are quite stable, and his sputum is also negative. Clinically, he is very well. So I agree with Dr. Puri that extending the treatment for some more time might help. But one has to be very careful and very, very
Cautious.
watchful about the patient, what is happening in this patient.
Thank you so much,
Since
sir.
it's
Quick
I would
comments
like
from
to add,
Dr.
Dr.
Puri
Sudha,
and Dr. Ritu. Dr. Puri, sir.
I would like to add that in the October sample, they should do the drug sensitivity for the parazinamide and ethambutol
मेरे
also
ड्राइवर को
in
आवाज
these
कर
cases.
डाले ऊपर
That we should know, and we should find out the reason why the patient has
Dr.
not
Raja.
got the resistance to INH and rifampicin in spite of the low level. To me, it seems the drugs are working. That's why the patient is improving. And I will like to say the serial chest x-rays of the patient over the 2 to 3 years, because Dr. Rishi has shown only me the first x-ray and the last x-ray. So we can also see in between the x-rays and see whether the response was there radiologically when he has stopped the treatment or not, or the disease is continuing it. If any of the four drugs, any two or one drug is resistant, probably this will not be effective or adequate treatment, then we need a longer treatment, because it is usually the parazinamide which help us to reduce the duration of treatment to 6 months. So though you said that it is sensitive at KGMC, I will like that it should be retested, parazinamide and ethambutol.
Thank you.
Sir, regarding X-rays, sir, the date in which all four X-rays are there, starting from 2023, April 2023 to latest X-rays also there. The slide, sir.
Okay, okay.
Yes, sir.
Right, sir. Dr. Ritu. Dr. Ritu, you've raised your hand.
When you unmute your mic.
I think she has some technical issue. Dr. Urvashi, ma'am, you want to say?
yeah, I'd like to just say that Dr. Puri raised DST to pyrazinamide and ethambutol. Now, both DSTs, there is an issue. Ethambutol DST is not recommended because it is not reproducible. Hence, it is not recommended. Regarding pyrazinamide DST, again, there is a debate. And what the experts recommend is, even if the laboratory reports it as resistant, it would be ideal to add in a regimen, primarily because all the drugs will act in synergism. Hence, practically, what is recommended is just resistance testing to rifampicin and INH. So, I would agree with Dr. Prasad, sir, that we enhance the dosage of rifampicin. Netherlands has traditionally treated at 35 mg per kg. We have had trials in our country where 35 mg per kg has also been used and found safe. So, enhancing the drug dosage, repeating the therapeutic drug levels to see if they are improved, and also looking for whether there's a co-infection with the non-tuberculous mycobacteria by molecular methods could help us. Thank you.
Ma'am, I'll just like to come in. I think earlier was not allowed to unmute. This is Dr. Ritu here. Just two observations. Firstly, NTP lab, the IRL at KGMU is an NTP lab. So the message should not go to get the DST done, that is the midget DST from a private lab. The issue is not there. The lab at KGMU is very well equipped to be able to carry out the DST. That's first observation. Secondly, molecular method would have picked up MTB. However, culture is also giving MTB, which is itself, if had there been NTM infection, mostly you would expect NTM infection to come in first. So
Dr. Ritu, they could coexist, and in the culture, if you're picking MTB, most people would ignore the NTM. I'm trying to say one has to look for NTM. It's a mixed culture. You need to identify the two separately. There's a special effort involved, which most people do not do.
Okay, ma'am.
Yes, I totally agree with the Urvasi. There could be combination because something is there. Why the response is so delayed and is recurring third time it has happened. So there are some factors which has to be worked out very thoroughly. He's a young man and a young boy, and that is a very important issue. And I receive her saying that only seeing the tick of the card and that sometimes, especially in a difficult scenario, may not help you. In difficult scenario, one has to talk with the patient, talk with the family, and find out what are the issues. Is he really adherent, or sometimes he is not adherent? What is his family background? What is the patient background? What type of personality he has? My teacher used to tell that there are some personalities from outside they look different, from inside they are different. So it is no doubt, to my experience, it's a difficult case, and probably we have to move an extra mile to find out why this is happening, and before thinking of changing. I think my personal also final comment is that before I would ask Rupak to say that the treatment has to be extended for some time and has to be followed up very regularly and see that what is happening. And as a disease is bilateral, so surgery is out of question. But the lesion, what I saw in the last X-ray, appears to be stable one. And that is also confirmed by the sputum smear for AFB is also negative. So probably some little more time has been, and we agree with we might think of increasing the dose of rifampicin, where there's very well studies are.
Sir, I think
now the yes.
Sir, I had asked from the patient myself that in which class you are. He said I was during the first time when he was had TB. He was going to give class 10 board exam, but because at that time he was not able to go to give exams, then the 10th exam he dropped. till now he is not able to give the 10 board exams. So I just counseled him to your studies. You should also study. Now you are you have got strength. You should go and study. You take up the class 10 exams and all these things. During these talks, I never found that he was this alcoholic or something like that, sir.
Dr. Rishi,
Thanks, sir.
Since I belong to Lucknow and he belongs to Kanpur, so I offer my services to see him free of cost. You please, if sometime
sure, sir, sure, arrange,
sir. You might arrange, and then I'll talk, because it is for the benefit of the patient and the country.
Sir.
So if some time required, you can discuss with me.
Sure, sir.
We belong to the same city, and I am ready to help.
डॉक्टर ऋषि, मेरा क्वेश्चन कोई निक्षय मित्र इसका था, इस पेशेंट का
नहीं सर, अभी नहीं सर, अभी नहीं है सर. मैं खुद ही बन जाऊंगा.
How we are talking about nutrition support to this patient? कहाँ से आएगा वो? जब पेशेंट नहीं अफोर्ड कर पाएगा तो कहाँ से आएगा फिर? तो कुछ ट्राई कीजिए ना इसके लिए.
NPY देते हैं और डॉक्टर ऋषि himself is responsible. Dr. Rishi himself is responsible if he has not insured Nikshay and Poshan Yojana 1,000 rupees per month.
Sir,
then he has to be blamed.
Yeah, madam, इनका जो first treatment हुआ था, first time I asked he got the full 3,000 rupees treatment at that time in the first treatment, and the second time he got 1,500 rupees. 1,500 rupees of second part is pending, and now for the third also he still has to go. This I have conveyed this message to the DTU Kanpur also, that ensure that the DBT should go and hand in hand also. This I asked and share the information
from 1st November, Dr. Rishi, we have enhanced the amount to 1,000 rupees per month. So the first, first installment will include that. You know, and for the month of October, he'll get 500. For the month of November onwards, he'll get 1,000 rupees.
Yeah, ma'am, we know. I've informed the DTU also, madam. Thank you, ma'am.
So thank you so much. We've been having such a interesting discussion. We have discussed role of nutrition, maybe the reasons could be due to low BMI, malabsorption. Somebody said maybe he's taking drugs with PPI, and we've had many suggestions so as to check the quality of drug. Then should we extend the treatment? Do we give him a better diet with the medicine? So all these discussions have come up. So now I request Dr. Singla, who is the expert for the day, to give his comments on this case. Over to Dr. Singla.
Thank you very much. First of all, I must thank Dr. Ushi Madam, our DT3C, who has spared her time, and she is there from the beginning of this case. It is almost more than 1 hour. Of course, Dr. Endra Prasad, senior colleague there, Dr. Puri, Dr. Shetty, all have given their opinion. I'll just like to share what I feel about this case, and of course, everybody's opinion has to be sort of respected when we take a final call. You see, if you review this case, patient received the first-line drugs 3 times. First in 2023 for 6 months, declared cured, even the sputum became negative. Then second time in 2024 for 5 months, March to July 24. But they found that the follow-up sputum, immediately after that, treatment was negative, but the follow-up sputum was positive. They declared patient as failed. That was in September 24. And after that, patient has been on these first-line 4 drugs with effect from September 24. The sputum by NAT, whether the CBNAT or the true NAT, it has been dip sensitive on multiple times. April 23, May 24, then September 24. And the first NLPA report is mentioned in the presentation of Dr. Rishi, where it showed INH as well as rifampicin sensitive, H high dose as well as the low dose. And the second NLPA report had shown sensitive to chloroquinones and SLI. Next slide. Next. Yes. So sputum culture was then, you see, something which is very little disturbing is that sputum culture had been done twice, June 24 from a non-accredited private lab. I feel this practice has to be sort of discouraged, especially in a state like UP, where we have accredited lab IRL is existing there, and they are doing a good job for so many years. So in these cases, we must take the help of accredited lab. And this lab on both the occasions, they have shown sensitive to INH, rifampicin, pyrazinamide, thionamide, amikacin, kanamycin, linezolid, clofazimine. And they found levofloxacin 1 microgram per ml to be sensitive, but moxifloxacin 0.25 microgram per ml to be resistant. Both the occasions. So again, I don't know how to interpret this. We have better people like Professor Urvashi who can comment on these kind of cases. Once she is there better, I don't open my mouth. So then because of the non-response, on 28th June, the patient was referred to our institute, and for the knowledge of everyone, our institute has started doing this the serum levels about a year back, and as of now, we are doing only for the first line drugs. And Dr. Devika, our biochemist, she is trying to do for the second line drugs also. And it showed there were low levels of INH and rifampicin with normal levels of pyrazinamide. Then the another thing is that culture has been done twice in KGMU. First in the May 24, which was positive, and then in October 24, which is again positive. So to say, you see, now we are told that on 4th of November, the smear is negative, so we feel that patient has converted. No. It is if October 24 culture is positive, I'll just ignore the sample of 4th of November that it is negative that patient has converted. No, it should not be taken like we have to respect the culture done in October 24 at KGMU. But unfortunately, in the presentation, I do not find the extended DST because this culture is there almost about 2-3 months old. This extended DST report, I think we should trace that out. It should be available because that will help us for our future treatment. Then patient was declared failed in September, and also patient is showing low level of INH plus rifampicin. This is the current issue. X-ray is deteriorating over the period of time. Now initially it was sort of mild to moderate, and now you find both the lungs are involved. There are cavitations. Left lung is practically the whole lung is involved, including the right lung also. And also patient says he has lost 2 kg of weight. Although when he says clinically fit, I do not know how to interpret this. Patient is malnourished. And the fact from 2024 September, patient is on first line drug. Next. No. Yeah. Wait. So when we talk about the management of this case, we need to, as everybody said, we need to doubly check whether the patient was compliant to treatment or not. Somebody also raised the issue of the quality of the drugs, but apparently looking at the stringent criteria government is using, they are of good quality, other patients are responding. We need to do the test for malabsorption and also look for any immune suppression if there is, because these are pretty why the level. Then sputum culture and DST, we should try to have the results from IRL, or we may take the help of NRL for the neo drugs. And even we may explore the role of TNGS also. Dr. Urvashi Madam is trying her best to scale up the facilities for the TNGS across the country. And so you see, if you look at the bottom line, is a young patient. He's a young patient and rapidly deteriorating X-ray. So we need a robust regimen. Now we have to save him. We have to save the lungs also from further damage. So then we come to the how to constitute the regimen in this case. First is, I think most of the people feel that we should give him a trial of high dose of INH as well as high dose of rifampicin. And you know what our experience has been, we have been treating such cases in an organized way, I can say, since 2016. Not very high, but almost just 8-9 years. But what we have found is that we get such cases because being a referral institute, that if patient comes to us early, suppose only 3 months, 4 months, or 4.5 months are there, and patient has shown low levels and not response to treatment, just by increasing the dosage, it has helped us. But once we have patients like this case, April 23, and now we are in January 25. So these patients who have taken for say 17 months, 18 months, or 9-10 months, in these cases, if we just increase the dosage, we find they are not improving. Even if they are found to be sensitive repeatedly, we find that they are not improving. And once we added them, the second line drugs, then we found that they are improving, they improved. And also we are following the policy that once we add the second line drugs or even first line, we try to see that we are able to give injectables to them so that at least we ensure the blood levels. There are two reasons for this. You see, if first lines are not being absorbed, we do not know whether the second line drugs will be absorbed or not in case they are given orally. Number one. Number two, we have the challenge of doing the TDM for the second line drugs in the country. So keeping these two things in mind, what policy we adopted for these patients who are not responding for long a period of time, maybe 10 months, 12 months, more than that, that we retain the first line drugs in high dosages and supplement them with the second line drugs, preferably in the injection form. So for in this case, from A, we should consider injectable linezolid. Then from group B, clofazimine and cycloserine injections are not available to be given orally. And group C, delamanid and injection amikacin. So we'll have the INH rifampicin 2 drugs plus 5, so around 7 drugs. Usually keeping in mind the pill count, the pill burden, we usually do not cross the 6 to 7 drugs total. Now, we know with rifampicin, we cannot give bedaquiline because it increases the metabolism of bedaquiline. So either we have to choose high dose rifampicin. In case we feel that no patient has taken it enough, then we can replace this with bedaquiline. Fluoroquinolone I am not suggesting because in this case on two occasions, maybe it's a private lab, unrecognized, the non-accredited lab, but it has shown moxifloxacin resistance 2.25. So, and now you see it's a question of saving the life, saving the lungs of the patient. So our regime has to be robust and at least we should be convinced that this will be acting because this may be the last chance for the patient in case even this regimen fails. So I'm not considering giving fluoroquinolone. So the final regimen which I am suggesting, of course, before that, you see the suggestion from Dr. Urushi madam about the NTM is very, very important. Normally what happens, we feel that no, the genotypic tests are not showing NTM, it is not NTM, but no, in case of mixed infections. And there are reports of mixed infection. And I remember less than a year back in the International Journal of TB and Lung Disease, there was an article on this, the MTB plus NTMs. So we should keep the possibility of NTM also in these cases. We should consult a good laboratory and identify whether both of these are present or not, because in case there are NTMs also and not being treated, patient will not respond. So coming back to the this regimen, one regimen is high dose INH rifampicin, injection linezolid, clofazimine, cycloserine, delamanid, and injection amikacin. Second option is that we do not give high dose rifampicin because he's taken it for long. We replace this with bedaquiline. And it goes without saying that we have to ensure the compliance. We have to improve the nutrition of the patient. In case we find anything and any signs of malabsorption, we need to take care of that also. And once patient put on this regimen, do the TDM again to really be sure that patient is absorbing drugs now, there are levels are maintained. We should do the TDM for the first line drugs as well as second line drugs after 2 to 3 weeks and follow the protocol of doing the TDMs. So I stop here. This is my my thought on this, and thank you very much.
Yeah, thank you, Dr. Singla. So we can take up the discussion now if there is any discussion on this. Yes, Dr. Puri, sir. Dr. Puri has raised his hand.
Dr. Singla, since we are going for the drugs which are used in the treatment of drug-resistant TB, should we go for the whole gene sequence of the sample or the culture, which fresh sample or the culture which is available to know the exact resistance pattern in this case? And secondly, why you are recommending injectable linezolid instead of the oral linezolid in this case?
Yes, you see, I covered these points. I said TNGS, which is a sort of genome sequencing only, to do the TNGS also to see it will be an add-on test to see the drug susceptibility to the drugs which we are thinking. And the reason for injectable linezolid is that we are, as of now, we are not sure patient is absorbing the drugs or not, whether first line or second line.
Okay.
So for the drug for which injection is available, I am preferring the injectable linezolid. That is the reason.
And any specific reason why the patient, in spite of having low level of INH and rifampicin, has not become resistant to rifampicin after 3 courses of rifampicin and INH?
Yes, it's a very relevant point, and we have been struggling hard for this for last 8, 10 years. That they have been taking it for sort of few months or 1 year, 1.5 years. They remain sputum positive, they remain sensitive, but they are not responding to treatment. So why they have not developed resistance? I think maybe Dr. Urvashi Madam can help us in this matter. I do not have the answer to this.
And I'll be able
Thank you.
to answer this. This is not a mathematical process. 1% of these colony forming units, if they become resistant, we call the culture as resistant. Now, it doesn't really happen, because we want it to happen. So this is always any culture is a mixture of several different heterogeneous mycobacteria. And you see, we give a cutoff of MIC to call it resistant, but the mixture or the heterogeneity in the culture can have mixture of bacteria responding to different inhibitory concentrations. So, this is a process of accumulation of resistance mutation. Drug resistance is a process where drug-resistant mutant coliformic units accumulate. Only when they're more than 1% will it be detected by whether it is phenotypic. For genotypic, in fact, we need more than 1% to be detected. This nobody may be even aware. Very few go into this much depth. So it is not that, as it is the frequency of mutation in case of rifampicin is 1 in 10 to the power 8. That is only when 10 to the power 8 mutations happen, 8 replications happen, one mutation will creep in. So it is not that it must always become resistant when it is exposed, but it could become resistant. So there is no timeline defined as to after how long of treatment on one particular drug the resistance will crop up. So that is the simple explanation.
Thank you so much, ma'am. Are there any comments or is there anything in the chat box?
Yeah, Dr. Neetu?
Only thing, Neetu.
Yes, sir.
Hello.
Sir, we can hear
I
you.
agree. What Dr. Rupak said, I agree. Whatever he has discussed. One or 2 points. I'm very clear that still, as her lesions are his lesions are very stable. Currently, sputum for FB is negative. So I think, and what Dr. Urubasi has discussed about the heteroresistance, and probably, although I'm not a microbiologist, but heteroresistance is there about 7-8% cases even in Indian bacterial population. So and I think the gene sequencing might help in detecting what short of this bacteria is, if there is a combined one, typical, non-typical. And what suggestion Dr. Rupak gave about the introducing a second line drug? Yes, in due because already there are 2 years. 2 years have passed, so you can wait for another 1 or 2 months, and pending these investigations, one can decide about the regimen, what Rupak has very vividly discussed. Thank you very much. Actually, I'm on the
I'd
way.
like to make
So
one
that's
more
why.
point. Just one more point, sir.
Yeah.
Sir, genomics can come to our aid when we do not have phenotypic DST. So TNGS may look very rosy because it is new, but like I said earlier, phenotypic DST will be the gold standard. Phenotypic DST, we use the cutoff of 1%. Even 1% heteroresistant population can be picked. All molecular methods have a worse. So
Yes.
phenotypic remains the gold standard, while
Yes,
genotypic can come
I
in
agree
handy.
with you.
Genotypic will come in handy जब culture
Urvashi, I
नहीं grow
agree
होगा.
with you. Urvashi, I agree with you, and but microbiologist, lab, and the person who is doing it, he has to be as competent as you are.
Thank you so much, sir. Dr. Manpreet has raised her hand. Yes, Dr. Manpreet.
Yes, sir. As told by Dr. Urvashi, it has been discussed phenotypic versus genotypic. So, but in this case, I think the only option we have, which we can try for doing the whole genome sequencing from the culture which is available, or we can take a fresh sample and do the TNGS, because like we can do it from the fresh sample.
Dr. Manpreet, even then, phenotypic will continue to remain the gold standard. Phenotypic actually replicating the in vivo atmosphere, right? So phenotypic, we go on to genotypic when our culture is not growing, or we want the report early. That is when our genotypic comes in handy.
Yes, only because in this case, like as it is being said that rifampicin is coming still sensitive after all, so we can try to look for some other mutations which may not, like, which are being missed by the phenotypic. That can
that'll add to our knowledge. Maybe some novel mutations, but what do you do about a novel mutation when phenotypically there is no resistance? I think we very clearly have that the drug levels are not reaching the optimal levels. And we need to just deal with that. And of course, rule out there is nothing else in addition to MTB, which is leading to new shadows. That should be able to help us out.
Thank you.
Thank you so much. Thank you, Dr. Manpreet.
Nita, the last word I wanted to say, I still offer my services for this case, because this case belongs to Kanpur, where I live in Lucknow, and we can at least we can talk together to the patient, find out whatever problems we have discussed, and I'm ready to offer my services for this patient. I'll just repeating it I said before also. Thank you very much. Actually, I'm going to the airport, so I'm on the road. So thank you, Nita, for.
Thank you so much, sir. Thank you for being for joining us and giving your expertise, sharing your expertise. So, if there are no more comments, we come to the end of our clinic today. So, I would just like to summarize. We've had yeah. So we've had a very interesting discussion today with so many things coming up. At the end, I would like to say that we should try that this kind of situation.
May I come in? Madam Lokendra ji there.
Yes, Dr. Lokendra.
Regarding the WGS, all the microbiologists discouraging that. I want to know that once we have a WGS for this patient, it can also analyze the evolutionary change of pathogens over time with the help of identify the emergence of new strain with the increased virulence or मेरे ख्याल से जो WGS का study है in individual case that can help the patient, as Dr. Manpreet Bhalla was saying, ma'am was saying, it helps to identify the emergence of even new strain. It might be a new strain which is not responding with the antitubercle treatment for the first line. That's why WGS can help. That's why I'm saying. Even Dr. Bhalla ma'am was also increasing the WGS. If any comment from Dr. Bhalla ma'am, we can tell us. It help identifying the emergence of new strain. We can identify the new strains.
Yeah, Dr. Lokendra, it will help for new identifying novel mutations. But as Dr. Urvashi said, for this patient, it's a different scenario here.
Yeah.
So in this patient, since the patient is not responding, like it will not be much useful, but we can do it for academic purposes. It can be done.
Even then, हो सकता है कुछ नया ही निकल आए.
Thank you, Dr. Lokendra, and thank you, Dr. Manpreet.
Dr. Rishi, आपसे एक request है humble. Please let us know in any clinics, what happens to this patient finally? Thank you so much.
Sir, I assure you all that I will be doing personally my follow-up also, and I will be adopting him as a Niksha Mitra also for this patient. So in this way, I will be doing both the things for this patient, sir.
Thank you.
That's a good,
Thank you, sir.
Initiative, Dr. Rishi. Congratulations for being the Niksha Mitra for this patient.
Thank you, ma'am.
Yeah. So at the end, I would just like to say that, we should try that the situation doesn't happen, and we should suspect the failures and non-responders as quickly as possible, and, send them to an accredited lab for culture and DST. We should ensure the compliance and try to, arrange nutrition for him so that he has good nutrition, and we should try to expand the facilities for TDM. So with this, we wind up this clinic, and now I request Dr. Ashok Bharadwaj sir, who is the chair of National Task Force, to give his.
Yes, sir, you are doing, sir.
First of all, I must thank Dr. Rishi Saxena. He is very energetic person. So he himself admitted. Then otherwise, I was going to direct him to be the Niksha Mitra of this patient. So, but I agree with Dr. Rishi. One of the reason, because I am a public health person, the reason is the malnutrition. So if we can cover that portion, then we will be doing a great to the patient. Of course, the Dr. Rajendra Prasad's comments, and then Dr. Puri's comments, then of course the final word, the person I keep him in high esteem, Dr. Rupak Singla. So wonderful comments by him. So I think somehow there was some deviation in the course of this treatment, because I don't see any relevance of doing CBNet 3-4 times. So we should follow the guidelines wherever it's possible, and make out our path like that only. The progress of the patient. Yes, the Dr. Prashad told that we have to take out the detailed history of the patient, but I think Dr. Rishi Saxena has already got the details of the patient. He has talked to him that in details, as because he served in Kanpur also previously, so he knows the patient very well. So again, I say that we should conform to the guidelines. We should not deviate from the guidelines. So I yesterday also, day before yesterday also, I discussed here that I attended the state clinics for 5-6 states in the southern part of the country. Somehow the guidelines they are not followed. The program guidelines should be followed in total. Only then we can have benefit to the patient and the impact to the patient. So we are all working under the program, and we have to work for the program. So thank you, Nita, for giving me a chance. So thank you, Dr. Rupak Singla, and God bless you. Thank you.
Thanks, sir.
Thank you so much, sir. And please, I request everyone to fill in the feedback form. The link is there in your chat box. Kindly give us your feedback. It's very valuable for us. So thank you again, and we close our clinic now. Thank you.
Thank you, sir. Thank you.
Thank you, everyone.
Thank you.